Okay, good afternoon again, everyone. If we can have your attention, and if you don't mind making your way back to your seats, we're going to get started with our next session. So I'm pleased to welcome Dr. James Marriott, who is an assistant professor in the section of neurology at the University of Manitoba, and I needed more coffee at lunchtime. And he is also an attending neurologist in the Winnipeg Multiple Sclerosis Clinic. His main research interest is in multiple sclerosis clinical trials. Dr. Marriott is a lead investigator for the mesenchymal stem cell therapy for Canadian MS patients, or otherwise known as MESCAMS study. The aim of this study is to determine if treatment with autologous, originating from the same person receiving treatment, mesenchymal stem cells in people with MS is safe, can reduce harmful inflammation in the brain, and possibly contribute to repair of the central nervous system. Please join me in welcoming Dr. Marriott.
Thank you. Okay. So I guess the mic sounds like it's working there. Okay. So thank you very much for this opportunity here to talk about two different types of stem cell therapies for multiple sclerosis. See that work there? Perfect. Okay. So just my disclosure slide. So I'm a principal investigator for the site for the ocrelizumab study for primary progressive MS in Winnipeg, and my other research support is through the MS Society of Canada, and for the MESCAMS trial specifically, the Research Manitoba, and then the Research Foundation associated with the MS Society of Canada with a generous grant from A&W Food Services Canada as well. So some of this may be old hat to a lot of you. You've seen similar slides before, but I thought it was important, first of all, just to start talking about what MS is from a biological level, and then how that relates to the stem cell therapies that are being tried in multiple sclerosis itself, and to talk about two specific types of stem cell therapies. The hematopoietic, which I find hard to pronounce, or blood stem cell, or the so-called bone marrow transplant, which is being widely studied in multiple sclerosis. And then the newer type of stem cell, which has attracted a lot of interest, mesenchymal stem cells, and then specifically the MESCAMS trial, which is being run partly out of Canada here. So MS is a autoimmune condition, and these sort of lame kind of cartoons here that I did sort of show two different immune cells, one of which is doing the good thing, which is the immune system should do, which is fight off that fluffy cloud, which is supposed to be a bacteria or a virus or something like that. So this is what the immune system is supposed to do, fight off infections and so forth. But in some individuals, immune cells also, unfortunately, go after part of the person themselves, shown here on the other slide, or the other half of the slide there. And these are a wide variety of different autoimmune conditions. Rheumatoid arthritis, where the immune system goes after someone's joints, juvenile diabetes, where it goes after the pancreas gland in the abdomen, and multiple sclerosis, where, of course, it goes after part of the central nervous system, the brain, and the spinal cord. And you've all seen slides similar to this before with a MRI depiction showing these white areas here, which are the most visible areas where the MS has affected someone's brain here. And if you look deep down under the microscope, you'd see something like this cartoon here, where the top half shows three different nerve cables, all of which are surrounded by these I think they sort of show up as bluey purple sections here, the so-called myelin sheath, which encapsulates and encloses around the nerve and acts essentially as an insulation for the nerve signals. And in multiple sclerosis, these green guys here are the immune system, which is starting to react against the person and specifically against the myelin there. I'm just going to adjust my slider so I can see my notes there. Okay, there we go. Okay, so this is another cartoon showing just a single nerve cell here with the myelin sheath intact, enclosing the main axon, or the main nerve cable coming off from the nervous system cell, from the nerve cell. And this normal acting nerve cell is able to fire very large, regular, active electrical impulses. When that myelin, though, becomes damaged in multiple sclerosis, the electrical impulses become further and far between, and they become less strong. And this is what translates down the road into all the actual symptoms that a person with MS experience. And if we look just at types of MS as well, and again, I apologize if you've seen this slide multiple times before other presentations or earlier today, but in terms of the different types of MS, these cartoons here show the main sort of subtypes that we recognize. There are people who have what's called relapsing remitting MS, where these little arrows represent periods of time where a symptom will come on, stay there for a while, and then hopefully dissipate and go away completely. Although in some people, as sort of emphasized by that little remainder of the gray area there, the symptoms do not improve 100% after the relapses. Some people who initially have relapses, I'm losing my marker here, these will then go on as the years go on, begin to develop more chronic symptoms that begin, don't go away, and slowly unfortunately become more and more obvious as the years go on as well. And this is a so-called secondary progressive type of MS. There are other individuals, probably about 10% or so of all persons with MS, who initially begin, though, with more of a progressive course right from the onset. So things just build up slowly as the years go on, sometimes with some superimposed relapses where they'll have little blips where symptoms get temporarily worse and then drop back down. So if you think of what the aims of multiple sclerosis therapies are, and this is sort of a reworking of a sort of a review article sort of talking about what we'd want to do in multiple sclerosis, you want to first of all reduce relapse rates in people who are having relapses. By reducing relapse rates, you want to decrease any residual or chronic symptoms or disability that originates from a relapse. You want to try and treat symptoms that are there, be they symptoms that will just be there for a brief period of time or more long-acting or ongoing or chronic symptoms. And you want to prevent disability going forward due to that progression that we saw in the previous cartoons. And the holy grail, if you will, would actually be to undo or reverse progression that's already started. And we are, to some extent, able to do 1 and 2. We can certainly do 3 to a limited extent, depending on the individual and the precise symptom. But the 4 and 5 is where really the next phase of research really has to be in terms of trying to tackle underlying progression, both in terms of stopping it from happening and trying to undo it down the road. So this is just a very, very famous, at least for neurologists, very famous painting of this guy standing here, Jean-Marie Charcot. And this is in the late 1800s. So he's not the first person to describe multiple sclerosis, but he certainly gave it its name, sclerose en plaques, on French, which translated down the road to the English phrase. And he was the first to sort of bring all the information together that was at the time and sort of treat this as a distinct condition going forward. And we've come a long way since his time, not just in terms of the gender balance of the medical students and residents in his class there, but also in terms of MS therapy itself. Because if he were giving this talk, he wouldn't have anything to talk about if he was just talking about disease-modifying therapies. And to show us the extent of how things have been rapidly changing over time, if one of my predecessors was giving this talk when I was in high school in the 1990s, again, there would have been no real discussion in terms of disease-modifying therapies. In my first year of residency, neurology residency, there were 4 therapies on the market in 2002. By the end of residency, you'd added on 1 monoclonal or injectable therapy, and this is where we are now. So this is certainly, to some extent, a great leap forward, and you can look at this both, from a glass half full perspective or from a glass half empty, and both ways of thinking or looking at that glass are correct, because we certainly have made substantial improvements in terms of the therapies that are on the market and useful in people with MS. But at the same time, I don't need to tell this audience that there's certainly a heck of a long way to go in terms of treating things going forward. So, sorry, I don't know why I showed that slide again there. Oh, and I don't know why I'm showing that slide again anyways. Okay, there we go. So if you look at the therapies that we have now in terms of disease-modifying therapies, they are really only helpful for those individuals who have a relapsing type of MS in terms of decreasing the number of relapses that happen and decreasing the severity of relapses and hopefully preventing residual problems from a relapse that doesn't resolve completely. We can treat symptoms to some extent in anybody with MS, but obviously depending on the person and the severity of the symptom, there's certainly a heck of a long way we need to go in treating individual problems. Oh, sorry, is there a question there?
Yes. I would like to ask you, according to that diagram, I've got secondary progressive, but then again, I'm in the extreme right-hand portion of it where I have very little or no relapses.
Mm-hmm.
So does that mean I graduate down to primary progressive or what?
No. Once people have secondary progressive MS, that's usually the term that we keep using for them going forward. Primary progressive MS is really where someone right from the onset doesn't have relapses, but they just have symptoms that gradually build up and build up.
So therefore, there are drugs available for secondary progressive. Is that correct?
Yes and no, sorry. So there are, if you look sort of at this slide here, people who are having relapses before they develop progressive MS, those are that we can help to some extent. And a lot of people who have secondary progressive MS still keep on therapies for a period of time because of the fact that we don't know if they are still going to be responding or if we're still helping with that. That's a good point. And we'll show this, and obviously there's been a lot of developments in progressive MS as well, which we'll touch on down the road in some later slides there. So in terms of treating symptoms, as I said, we can treat symptoms to some extent very well in individual people, but again, there's obviously some things which there's an enormous need for symptomatic therapies. Where a lot of research has to be focused going forward is on treating the various types of progression, as I was saying. And this is where we sort of start to talk more about stem cells as a potential option. And for everybody with MS, there's obviously an unmet need, regardless of how the MS has affected them. Early stages, people who have a lot of issues with MS, people who have minimal issues with MS, there's still a lot of room to move in everybody. So leaving aside issues of symptoms and things like that, just getting back to sort of those little cartoons in terms of what we want a therapy to do. Ideally, we want a therapy to prevent damage to the nervous system in the first place. So if you can keep these nerve cables here with the myelin sheath all intact, if we can prevent the immune system from going after the nervous system in the first place, that's obviously one key thing that we want to do. What we would like to do as well is also be able to reverse problems. So when the myelin is being, in this cartoon, very severely damaged and stripped off these nerve cables here, it'd be nice if we could go back and actually have that myelin regrow and allow function to return. So some more droning on just about stem cells themselves, so we know what we're dealing with here. So the hematopoietic or blood stem cells and mesenchymal stem cells. So another one of my little cartoons here showing the differences between different types of cells and stem cells in the body. So if we look at a neuron, for example, there are some caveats to this which I'm which are out of my pay grade in terms of understanding. But most of the times, the nerve cells that we have right now, or the nerve cells, are all the nerve cells we're ever going to get. And nerve cells themselves, once they're there in adolescence and early adulthood, they don't grow, they don't multiply, they don't change over time. So a nervous system cell or a neuron that's what we have is what we got. Some cells in the body, though, can regrow to a certain extent. And if someone, say, damages their liver in a car accident or whatever, there is some capability of a liver cell to actually grow and divide into two identical liver cells and regrow part of the liver to a certain extent. And this happens even just when you injure yourself and you cut your skin or something like that. The body can sort of heal to a certain extent with a cell that can divide into identical cells from its parent cell. A stem cell, though, can do two different types of things. It can also create daughter stem cells, which can basically circle back and forth, creating essentially a line of cells that, as long as the person is alive, or the animal or the plant or what have you, those cells remain alive throughout the entirety of that person or that organism's lifespan. But the stem cells can also divide into other more specialized cells, such as liver cells or such as nerve cells. So it's that dual properties that really define a stem cell. I should have acknowledged I stole this slide from the MS Society website. They're talking about the MESCAMS trial. But if we think of different types of stem cells themselves, over here, if you look at where the green circle is, in an embryo, basically all cells are stem cells because it's a very small group of cells that have basically got to create the entire organism or person or what have you. In adults, stem cells are more specialized in that if you have, say, in the green at the top, a stem cell for the nervous tissue, it can create all sorts of different nerve cells and different types of cells in the brain and the spine, but it can't create other types of cells. Similarly, a blood stem cell could create all the different types of blood cells, red blood cells, white blood cells, and the various subtypes, but it can't create other types of cells. And down here, we have a mesenchymal stem cell, which you can create all sorts of different types of cells as well, but within a defined range. So the different types of stem cells that can do different things. When people think of stem cells as well, I'll just make this comment here. What a lot of research is going on is trying to take an adult cell and actually reverse engineer it to actually create a stem cell that can go on and develop into something else. This is not what we'll be talking about here today, and this is still sort of sci-fi and that sort of regrowing organs or limbs or things like that, which hopefully, of course, there'll be a lot of more opportunities for that down the road, but that's still a very early phase. If you think about stem cells within the blood stem cells or the mesenchymal stem cells, if you look at a bone under a microscope, the bone is actually not solid. There are all these little holes within the bone. And again, if you look at a cartoon of a bone here, you can see where these little cavities within the bone where the different types of stem cells hang out. And these ones here called HSC would be the hematopoietic stem cells, or the so-called blood stem cells. Also within the bone marrow, beside the blood stem cells, you have over here in the red box the mesenchymal stem cell, which, just to confuse things, this slide calls it something different, a stromal progenitor cell. You got to make things confusing. You can't just use the same name for one thing. There's got to be 15 different names for every different type of thing in medicine. But in any event, so the two different types of stem cells hang out in the bone marrow itself. If we talk about bone marrow transplants, though, what we're really talking about are the hematopoietic stem cells, the blood stem cells. And this cartoon from an early paper talking about how bone marrow transplants would work in someone with MS, and hopefully you can see my pointer here on both slides. So what is done in this type of procedure is that medications are given to a person to actually move the blood stem cells from the bone marrow out into the bloodstream, where they can be harvested intravenously. So you're collecting the stem cells from the blood. Then the person is given a combination of chemotherapy drugs and or radiation therapy and this removes all the stem cells and all the blood cells, the immune system cells that are in the person. Then you reinfuse what you took out from the person before, just the stem cells. There's a period of time where the person potentially could be quite sick because they have no immune system, or they have very limited immunity, and they have no red blood cells either, depending on the circumstance. And then their own stem cells regraft or go back into the bone marrow, start to repopulate, and the immune system and the rest of the blood cells pop back. This is obviously a therapy that's used primarily in people with different types of blood cell cancers, lymphoma, leukemia, and things like that. As this slide kind of emphasizes with the fact that these individuals are given chemotherapy drugs to, in the case of a cancer patient, it's to remove all the abnormal cancerous blood cells and then repopulate the immune system back again with the stem cells by themselves without any of the downstream ones that have become cancerous. How this applies to multiple sclerosis and to other autoimmune conditions is if you think about the rationale for a bone marrow transplant, thinking back to what we know of how MS develops in the first place. And we don't have an overall answer as to why people get MS. There's perhaps not one single answer, but multiple different answers in different individuals and different populations that kind of come together. But certainly we do know two things. You need to be born with an immune system, or the genes that control the immune system that predispose someone to get multiple sclerosis. And you need to be exposed to some aspects of the environment, vitamin D exposure, Epstein-Barr viruses that can cause mono, and a bunch of other things that have been found to some extent be linked to MS. Those environmental exposures interact with the immune system in the growing person, and it's that coming together of these two forces that cause multiple sclerosis. What we're doing with a bone marrow transplant is that we are basically, I should add as well, as one grows over time, as a child, young adult, and so forth, your immune system is constantly being reshaped because of the exposures. And this is all good to a certain extent, in that, if you vaccines work exactly by this principle, is that you're given a vaccine so that if you then encounter mumps or rubella in the population, you're not going to develop it yourself because you've already developed antibodies to the virus, and that's a good thing. But the bad thing is where you can also turn the immune system against part of the person themselves and bring on an autoimmune condition like MS. But if you think about a bone marrow transplant, you're taking the naive immune system, including the genes that you were born with, and you're basically resetting it. You're removing all the downstream effects that the environment had. And think of it just as a hard reset on your phone or computer or something like that. You're basically wiping the slate clean. The person is still going to be left with the same genes that predispose them to get MS. But if that person is now, say, in their early 40s, their immune system is the immune system that they had when they were 0 days old. So it's not got that 40-year period of other stuff happening to influence things and bring on the MS itself. So the hope is that you're resetting things and preventing problems going forward. Does that make sense to everybody? Okay. So there's been a lot of different research done over the years, and I'll focus for, obviously because we're speaking in Canada here, I'll focus just on one particular trial, which I'm sure you've all heard about in the news, which was the recently announced, or a couple of years ago announced trial from the Ottawa group. This here shows Doctors Friedman and Atkins, the neurologist and hematologist, Marjorie, one of the nurses there, and this lady, I'm actually blanking on her name right now, who was actually an MS ambassador for this, MS Society ambassador for this trial. What this trial did was to do a bone marrow transplants in people with MS who were unfortunately having a lot of problems develop quite rapidly, a lot of inflammation on their MRI scans, a lot of new clinical issues that were developing, and try and do exactly what we said about before, about take out their current immune system and reboot it. And to some extent, this trial was fantastically successful in doing just that. This slide here shows, I think the first, I can't even see my things itself. I think this shows, I believe, this shows clinical symptoms or new relapses, and this slide over here shows changes in MRI scan. And the line down here represents when persons got the bone marrow transplant. All the red activity is on this slide here showing relapses that people had before they went into the trial. And over here, it's showing all their MRI activity before they went into the trial. And as you can see, with the exception, I think, of just one, it's probably, I can't even see it on my own thing here. I should have blown up the original paper myself to remind myself which line it is, but there is one individual who had one MRI change shortly after they got the bone marrow transplant, where there was one new spot developed on their MRI scan. Otherwise, in this 20 or so group of individuals, the bone marrow transplant was extraordinarily effective in preventing new inflammatory changes as seen either in terms of clinical relapses or in terms of MRI changes. It's important to note, though, that of these, there were 7 people in the trial who still continued to have some progression of pre-existing problems that they had. So this trial did not completely stop everything, but certainly in a sizable number of individuals was very effective in preventing new changes over time. And that lady who is the MS ambassador is doing fantastically well. I don't think on any, at least as of when I heard her speak a couple of years ago at MS Society, was doing fantastically well at that time. So, bone marrow transplant certainly seems to be very effective. This is just another slide showing, this is 2, and again, you don't need to memorize this or anything like that. And this slide here just shows 2 different other groups, I think one Swedish and one American study of bone marrow transplants in their populations. And over here are some comparisons in terms of these people here with the orange dots would be people who are in the placebo arms of the standard clinical trials that have been done for typical therapies like Avonex and Copaxone and so forth. And these here in the blue dots show changes over time in people on active therapy, either in a clinical trial or in various cohorts that have been followed of people who've been on therapy and approved therapies and follow them over time. And this shows years in terms of how long people were followed for. And this axis over here shows an outcome called NEDA, which stands for no evidence of disease activity, meaning that the person has no signs of relapse, no signs of any change on the MRI, and no progression of any pre-existing problems that they may have. So it's a very solid endpoint in terms of what we'd ideally want to see. And what you can see is certainly in these cohorts, stem cell therapies or bone marrow transplants certainly seem to be more effective than traditional therapies. These are not head-to-head studies, so you can't 100% say that this is certainly what would happen. But they certainly do seem to be effective. But it's important to note that the effectiveness is not 100%, and that over time, these people still developed, on average, some changes as time went on. So should everybody get a bone marrow transplant? And the answer is no, really, for a few reasons, which we'll talk about here. First of all, as one can imagine, the fact that the bone marrow by necessity involves giving people high doses of chemotherapy, and depending on the center and where it's being done, potentially even radiation therapy as well, to remove all their normal bone marrow before doing it back in. There is an upfront risk of death, which is about 5%. And unfortunately, one of the patients treated in Ottawa did pass away as a complication of the treatment. And this is being found in all the other bone marrow studies. If you are someone who has a blood cell cancer and you could potentially cure or be cured or have a substantially significant risk or chance of having very, very prolonged survival with a bone marrow transplant, that mortality risk is something which most people would obviously go for. Not that the hematology doctors aren't trying to make it even better and to reduce complications, but in terms of the risk-benefit, given that you have a devastating illness which needs to get rapid therapy, it makes sense to treat people very, very aggressively. In multiple sclerosis, this is a condition which, thankfully, despite all the complications, again, as you all know, that can happen with MS, there is not that immediate sort of risk that you have if you have lymphoma. So the mortality question is certainly a very significant one. Coupled with the fact is that this is only really still getting at the initial phase of MS or the initial relapsing, if you will, subtype of MS, where people are having a lot of changes on the surface on their MRI scans. The immune system is very, very active. As both the trial in Ottawa and as the other trials done across the world have shown with bone marrow transplants, if people already have some degree of progression, be it secondary progression after having a relapsing course or primary progression right from the get-go, these therapies are not that effective. I'm just showing this slide again just to remind myself this lady who was treated in Ottawa herself brought up a very, very important point, is that when this Ottawa trial began, it was when there were only the 4 first-line ABCR therapies on the market. Now we have this, which have highlighted sort of, you've got therapies which are highlighted in red there, which are much more aggressive and much more powerful therapies for the most part than the therapies that were initially developed for MS. So one issue that we have now in terms of thinking about bone marrow transplants is, should someone who has very, very active MS, should they potentially be a candidate for a bone marrow transplant, or should they get one of the other newer therapies, including some of the intravenous therapies, which we know are much more powerful? And indeed, people who will get a bone marrow transplant, typically they're actually given one alemtuzumab or Lemtrada as part of the chemotherapy, if you will, in the first place. So it's hard to know what to do. Which brings us to the fact that what we need to do to sort that out is would be to actually have a clinical trial. And this trial is not up and running yet, but the hope is that at some point a clinical trial is going to get done and is being talked about quite a lot in the MS community, where you take people who are put on a first-line therapy, and if they have more problems despite being on that therapy, actually randomize them to go on a stronger approved therapy that's out there, or randomized to get a bone marrow transplant and compare. So you're actually comparing the new drugs that are available to a bone marrow transplant itself. This may be very hard to do logistically and in terms of setting up a trial like this, but this would be how we hope to sort of resolve that question. Okay. So turning now to the other type of stem cell therapy, mesenchymal stem cells. And just to show this diagram again, just to highlight the fact that these guys also hang out in the bone marrow, along with the blood stem cells, or the hematopoietic stem cells. These types of stem cells we know can develop into different cell types in the body, such as bone cells, fat cells, especially in the growing body. But this is not what we think they're really useful in the context of MS. What's been shown, and I'm not an expert in terms of the actual biology of this in terms of animal models and things like this, but there's been a huge amount of work done in the laboratory studying stem cells, these mesenchymal stem cells, and they certainly seem to be very effective at regenerating tissues, protecting tissues, and also seem to have an immunosuppressive or immunomodulatory factor. And basically, we want all 3 of these things in a quote-unquote ideal multiple sclerosis therapy. We'd want something that not only goes after and prevents the immune system from attacking the body in the first place, but also to protecting the body, stimulating the nervous system to be more resilient to the immune system going after it, and also potentially regenerating tissue as well. Again, I don't expect you to memorize or even be able to read that slide, but mesenchymal stem cells are being studied in a huge number of different conditions because of the fact that they do seem to have these potentially regenerative properties. So people who've had heart attacks and things like that, there are studies that work to see if they can be helpful outside of our focus here in terms of multiple sclerosis. And we're not sort of just making this up in terms of it sounds good, let's see if let's give it a go. There is some very compelling data from animal studies and from laboratory and in humans showing that these cells might be helpful. This slide here shows a mouse model for multiple sclerosis, which in mice is called EAE, is the acronym for the MS-like condition, which you can bring on in mice. And these mice, 2 separate groups of mice were given at 10 days, they were given a placebo injection, or they were given copies of their mesenchymal stem cells back. And I'll talk a bit more about how we collect mesenchymal stem cells in a minute. But in any event, this slide, so higher numbers over here mean the mice had more symptoms. And in the group, which are the open circles here, these are the mice who were given the mesenchymal stem cells, and they obviously did better than the group who was not. So this is after you induce the EAE or induce the MS-like condition here at day 0, let things play out, and then you give the injection there of the placebo or the stem cells and watch what happens to the mice after the fact. This is another slide here. This is a study that was done in the United Kingdom and people with MS, all different types of subtypes of MS who had optic neuritis. And they were given mesenchymal stem cells. And again, the actual, this is 3 separate ways of looking at visual system recovery. And again, you can't even read it or even look at any of the numbers or anything on there. But basically what it's showing here is this, so time 0, and then after the stem cells are given, and then for each of these graphs down the road, this is when the nerve, the visual function was checked again. 3 separate ways of looking at visual function, and in the outer 2 graphs, just take my word for it, the higher numbers are better. So numbers at the top of the graph here would show more visual recovery. This central way of looking at visual function, actually a lower number means there's been more recovery. And if you just look at each individual line here, which is an individual person treated in this trial, some people didn't seem to do anything, so that's basically just a kind of flat line here. This person, things seem to actually get worse. So they started out here, and then they had worse visual function at the end. And this person went in the opposite direction, so they actually did better at the end of the trial. If you look at the red lines, which hopefully you can see there, the average of each of these small groups of people did show that even though individual people, things were either got better or got worse, on average, with all 3 different ways of looking at visual function, there's certainly a trend towards improvement after mesenchymal stem cell infusions. So there is some compelling data to show that this may be a good treatment option for people with MS. Which brings us to the MESCAMS or MESCAMS trial. MESCAMS, and I won't go over the exact what these acronyms mean, but we'll show that the Canadian trial is part of a large multinational center looking at all doing the same trial going forward to study this. The reason why this approach was used is to contrast it with what was done before with bone marrow transplants in MS. And this just shows 3 title pages from 3 different articles from 3 different groups, all published just shortly before the Ottawa data was announced. 3 separate studies of bone marrow transplant, different ways of doing the bone marrow transplant, different groups of people with MS who got the bone marrow transplant, different periods of follow-up. Everything was different. So similar to what I think, unfortunately I missed a lot of this morning, but similar to what you heard earlier about the cannabinoid trials where different people looked at different things, it's hard to bring this all together and make a conclusive argument. Some people who do bone marrow transplants use much lower doses of chemotherapy to try and prevent problems, including risk of death or mortality. Other people use much higher doses in the fact that if you're going to do this and subject the person to the risk, you want to give them the most potential benefit. All different ways of doing it. And this has created a lot of uncertainty in terms of how you would actually use bone marrow transplants in clinical practice. So the idea of the MESCAMS trial is if we're looking at mesenchymal stem cells, then every different clinic do their own different thing. Even if we're not, is to everybody do basically the same thing. If you think about the standard trials for MS therapies, for disease-modifying therapies, your Avonex, Gilenya, all that type of stuff, these are all obviously funded by the pharmaceutical companies who have quite huge budgets, and they can afford to do a huge trial in multiple different countries, multiple sites in different countries, and recruit a huge number, in some cases up to thousands of individuals with MS worldwide, and follow them. And this is one company doing one study Everything's all done together. We don't have the capability, because of funding issues, to do similar trials with this type of therapy, either any type of stem therapy, or indeed any other therapy that's on the market that's already out there that's not. But if different societies, including sort of different funding agencies, pool their resources together and fund trials in individual countries or in individual centers, and each of those studies is doing exactly the same thing, you can mimic a large-scale pharma trial with multiple different budgets, which is how the MESCAMS trial came about. So we obviously have funding here locally with Research Manitoba and the Multiple Sclerosis Society of Canada. The Italian MS Society funded the Italian arm. The Danish MS Society funded the Denmark arm, and so forth. The primary goal of the MESCAMS trial was to show safety of therapy in people with MS. So that's the primary goal. Is the therapy safe? Not does it work, but is it safe? And most initial trials will do that because that's obviously the most pressing problem to ask. Related to that, though, there is another not so-called co-primary endpoint looking at disease activity from MRI perspective in people treated in this trial. And what I'll just say about this is even though this is not a measure of how well the person feels they are doing or an actual clinical endpoint, we do know that MRI is a very sensitive measure for overall effectiveness of standard disease-modifying therapies in MS. Every MS therapy we have on the market now that underwent two, for the most part, large-scale clinical trials to prove that it worked in terms of reducing relapses and so forth. All those therapies, were also effective in much shorter trials where MRI was used as a marker, usually at 6 months. So if you can see a benefit in MRI at 6 months, you've got a pretty good suggestion that that is actually going to be something that's going to be noticeable to people in a clinical trial going forward. This trial, though, wasn't only focused on looking at MRI activity, meaning as a sort of marker of inflammation or relapses, but also there's a lot of effort and thinking went into the trial to look for actual signs of nervous system repair using specialized MRI sequences, clinical exams, including measures of visual function and measures of cognition, looking in the blood samples following over time to see if we could see if there was changes in the immune system cells in the blood, as well as for assessing for patient-related outcomes such as fatigue and quality of life. In Canada, we are trying to recruit roughly 40 people overall, and this is part of a larger study of 160 people, give or take, worldwide, which is the MESCAMS trial, of which MESCAMS is a single country component of that. Most of the other countries are in Europe. Iran as well has also been involved in the trial. As I said earlier, this is a very unique trial in terms of how it's being done, and that the different agencies locally at the national level have used their own local resources to fund the trial, but everyone's doing the same thing. So it's the same trial across the board, not Canada using a different protocol to Italy, to England, and so forth. So if we're all doing the same thing, it enables us to get an answer faster and with fewer people exposed to the therapy as well. In case of this is something that actually makes things potentially worse. So we're mimicking a more large-scale pharmaceutical trial. So what's actually involved in the trial itself? So in terms of how the mesenchymal stem cells are collected, this is the most PG-13 slide I could find, showing unlike bone marrow transplants, where the blood cells you can actually give drugs that will move those blood stem cells from the bone marrow into the bloodstream. With mesenchymal stem cells, you can't do that. So it doesn't mean actually going into the hip bone to actually extract the cells themselves. I've never had it done, but I've been assured by the hematology doctors, the people who do this, that it is not as bad as it looks on that slide there. in terms of it being a relatively fast procedure. And people usually will have some tenderness as you would expect, but is usually something which people can tolerate very, very well. After you collect the cells, in the fraction of bone marrow that you are collecting, and if you look at this needle here, and just imagine this being a sort of regular, needle about yay long or so, you're collecting a very, very small amount of tissue, some of which will be bone tissue and supporting tissue. And then within that, there's a very, very small number of cells. And less than 1% or so of the actual cells you would get from this are what you want, which is mesenchymal stem cells. Which is why after you collect it, we then spend 8 weeks where the cells are purified in the lab. So there are different ways in which all the other cells are removed. So you just have a pure population of the person's own mesenchymal stem cells. And then over 8 weeks, that relatively very, very small number that you collected is magnified a gazillion-fold because you actually reinfuse millions of cells for every kilogram of the person's weight. And this takes 8 weeks to actually generate that number of cells. So there are some places, centers, shall we call them, in the U.S., in Europe, not in Canada, in the Caribbean, where are offering stem cell procedures, and people are getting their stem cells harvested and getting a procedure done the next day or something. In reality, we are doing this over an 8-week period to actually collect enough of the person's stem cells to actually generate enough to actually have a biological effect. And then this cartoon, which I stole from the web, shows someone just getting an IV therapy. And so the stem cells, even though you need to get them from the bone marrow, when they are purified and magnified and then reinfused, it's all done intravenously. And this whole cycle takes about 8 weeks to collect the bone marrow, purify it, expand the mesenchymal stem cells, and then reinfuse them. The trial itself is also, and again, that text is way too small to actually read, or anybody to read, but just to follow it's important just to point out that this is a trial that the whole trial runs for 12 months for each person. So there's a 6-month, the first 6 months here in this circle, or that rectangle, then the second section of the trial, second phase of the trial down here. Everybody who is enrolled in this trial in Canada or elsewhere, they are all getting an infusion of their stem cells back again, but they are randomized to either get that in the first phase or the second phase. This means we can do two things. So if someone is randomized to get early treatment, they come down here and they get an infusion. If they're randomized to get a delayed treatment, in the first phase they get a placebo or sham infusion. We follow them for 6 months, then each group crosses over and gets the opposite. The person doesn't know, the investigators don't know, so everyone is unaware of who got what, which makes us, keeps us honest in terms of when we score things and when the person who is in the trial reports how they're feeling, we are going to get a more accurate answer if everyone is so-called blinded to because there's huge unconscious issues in terms of if you know what you're getting, or if as an investigator you know what you've given someone, and that is being clearly shown that does influence how you report how you're feeling, as you can imagine. So at the 6-month mark in this trial, we're able to sort of compare directly people who got the infusion versus people who didn't, and with the MRI endpoint, make a statement as to whether or not the stem cells seem to have any impact in terms of MRI activity. But by following people for the full 12 months of the study, we are able to get more long-term data to see if people who were given went too far here, see if people had more changes in terms of their blood cells, more changes in terms of more long-term endpoints, including potentially some reparative signals, which is the main or one of the primary goals of this trial. But everybody is getting the therapy at some point. I just threw this slide in here as well to emphasize the fact that this has been a sort of staggered trial because not just in our center or in Ottawa, but in any center, this is something which is very intensive in terms of the resources needed. Most labs where this is done, or all labs where this is done, I should say, they need to be very, very rigorous in terms of their environmental monitoring and things like that. Similar to some of the pharmacies where they're actually making different antibiotics or drugs in a hospital. It needs to be the highest level of sterile environment to do this type of therapy. Because of that, the spaces have to be small, and because they have to be small, you can't really do too many therapies all at once. So most centers doing this, you can only actually be growing stem cells for up to 2, depending on the lab, 4 people at a given moment, which is one reason why this trial is dragged on for such a long period of time. Excuse me, not just in Canada, but across the world, because of the fact that you can't just throw everybody in the trial right away. You need to actually follow them. When one person is the stem cells out of the lab, you can then enroll someone else to grow their stem cells. 8 weeks later, someone else can come in, and so forth. So an individual person, as shown by these blue lines here, is in the trial for about a year, give or take. But overall, the trial is taking a number of years because you need to be staggering people like this over time. Okay. So just to go back to in terms of the context of the mesenchymal stem cells, if you think back to one of the slides that I showed earlier, the whole reason why we're doing this type of trial is to see if this lives up to its potential hype in terms of being something which goes after everything that we would want in a quote-unquote ideal therapy for MS, in terms of something that can be immunosuppressive in terms of fighting off the immune system attack on the nervous system, protect the nervous system in the first place from the immune system going at it, and also potentially have a reparative component where it actually enhances recovery. So we're trying to do both things. We're trying to prevent the initial problem in the first place, and we're trying to undo any problems that already have occurred. And this is very ambitious, obviously, but it's something that we hopefully will see some positive results from. And this is actually a sort of, if you think about this type of trial, it's part of a new wave of therapies and sort of we have done, if you think back to some of those earlier slides, there's been a huge explosion in the number of drugs that are available for relapsing type of MS and more powerful relapsing therapies. But we need to definitely develop therapies that increase the number of people who we can offer medications to, or therapies, I should say, because this is not really medication. So having people with progressive MS being able to offer more people something that's going to be of an impact in terms of their progression, in terms of undoing it, or in terms of stopping it or slowing it down. Also, this could potentially be considered as an add-on therapy. A lot of conditions that are out there, people are on multiple different drugs for. Someone with high blood pressure, if they don't respond to one drug for the high blood pressure, you add on a second one or a third one until eventually, you get things under better control. We don't have a capability to do that in MS yet. None of these drugs that we have for MS is felt to be either effective as add-on therapy when that's being checked, or safe as an add-on therapy because of the potential for immune systems to be too dysregulated if you throw too many drugs into the mixture. But if this is indeed a very, very safe therapy, then potentially we could start adding it on to other therapies that people are already on as well. One important point I forgot to mention in terms of safety is that even though I highlighted on my slide, I always forget to mention this. We think these therapies are safe, and the reason why we think the mesenchymal stem cells are safe is because they're already being used very commonly in people who've had a bone marrow transplant for leukemia or lymphoma or what have you, and the body is rejecting the transplant. Mesenchymal stem cells are able to be given to those individuals and clamp down on the reaction. Sorry, the other way around, I should say, with the fact that the new immune system that somebody's being given starts attacking them. We already have one clinical scenario where these therapies are very, very effective in helping to clamp down on the immune system in that particular context of someone who's had a bone marrow transplant. So in those circumstances, it's safe. So we don't see a reason why this would not be safe in people with MS. But again, we need to prove that more definitively with a large trial. The other point, which I've sort of banged on about a little before, is that this is a new way of actually doing clinical research, in the sense that this is not a pharma-funded trial, and it's a trial in which various different agencies around the world are pooling resources to get an answer faster by using relatively small sources of funding at the national level to do a national study, which is part of a larger conglomeration. And this is certainly going the way that we're going to need to move forward with trials. So again, if you think back to the unmet need, potentially mesenchymal stem cells could help in all aspects, in all different types of multiple sclerosis, and at all different stages of MS. That's the hope. We need to show this with the clinical trial. Okay, so what we would hope then is that we're going to be able to move on from this trial into larger scale trials afterwards, perhaps different ways of infusing mesenchymal stem cells to get more of a boost in terms of the immune system function. And I'll just close on this one slide here, which is, I was trying to find the reference. I gave this talk before and I used the same slide, and I didn't go back and try and find it again. But I remember reading some article, which is an article talking about scientific progress and the fact that things can kind of go off in different directions. And I think the title of the article was something along the lines of, "We were promised jetpacks." There's actually when I was Googling it, there's actually a Scottish rock band that have called themselves We Were Promised Jetpacks. But the purpose of this article was to really highlight the fact that when you're doing any type of science, you can expect the unexpected. And a lot of developments in the field of MS have actually happened in a way by accident. The initial drugs used in MS, the interferons, they were used. The hypothesis going into the initial trials of interferons was that there was a virus that was directly causing MS. And if you give an interferon, which has antiviral properties, you're preventing that virus from causing MS. As far as we can tell, there is no virus that directly causes MS, maybe indirectly influencing the immune system. So that theory was wrong, but the treatment was certainly effective. By accident. Same with Copaxone. Copaxone was initially developed to create a mouse model of MS. The researchers figured if we use what we now call Copaxone and inject it into mice, it will cause MS. In fact, those mice were actually resilient and were less likely to develop MS, or the MS condition in mice. So both of the standard therapies that have been around now for 20-ish years in MS, both of those, the science that went into them, the hypothesis was really wrong, but there is still a potential benefit. And the same thing with the jetpack idea. The people who were back in this 1930s, we were going on about the Buck Rogers style stuff and things like that. We don't obviously have jetpacks now, but that led to all sorts of other basically engineering developments that we use day in and day out in our daily lives, which you probably don't even know about and don't make the connection to the research that was originally done for a different reason. So with something like mesenchymal stem cells, this is something which initially you wonder what is the application to MS, and then you sort of read and you hear about the different ways, at least from my perspective, that there is some biological rationale. Then you're doing a clinical trial. Even if this trial is not a home run, the hope is that we're still going to learn a lot about the underlying issues in multiple sclerosis, perhaps make a better trial going forward. So I'll finish on that as well. Just one final thank you for the MESCAMS funders. Got the umbrella yanking me off. The MS Society of Canada, Research Manitoba, and A&W for funding the MESCAMS trial. Okay, so I think we got time for questions. So, okay.
When I heard that you were coming and speaking about stem cell, I dug into my old library and found a VHS tape of W5, and it had a woman that was going to do the treatment. And it was, I think it was 1994, 95. And so it led up to somebody before her that was doing it actually died in that treatment. And then she did follow through after they investigated, went back to ground zero and checked it all out and put her through that treatment. I was interested in knowing if that was the ambassador after that, all those years.
Okay.
Because I always wondered how she did, and actually I should have done that before I came to this, was investigate if I could find her or anything, but.
Yeah. So, I don't know, to be honest, but certainly there was I think when this trial started, my mic's coming in and out there. When this trial started, there was certainly a lot of media interest in it for obvious reasons, because of the bone marrow transplant trial run out of Ottawa was such a
What?
Okay, so yeah, so can you hear me now? Okay. So there's certainly a lot of media interest in the trial in the early stages as well, certainly. It was the same. Yeah. So yeah. There was about 20 people enrolled in that trial. So it might have been the same one that was on the news before getting the therapy, but there's a lot of people, I think, who, particularly the one who spoke at a function at the MS Society, I think a couple of years ago, a large pan-Canadian MS Society function. But there's other people who've spoken about the trial as well.
Yeah, I think if I can just add, I think the woman's name, I think I heard somebody say it was Jennifer Molson. Yep. So if you Google her, and I think actually Dr. Friedman might even have a little bit about her story on his links to his
the MS
website.
Society. Okay. Third time here. So I think on the website actually for the MS Society as well, I think there's some videos there for just. I forgot to check her name and I was blanking on it this morning. I'm sorry? Oh, Zamboni? Zamboni, yeah. Okay, that's okay. So this doesn't directly relate to what we're chatting about now, but the Canadian trial for that procedure, which was run out of the British Columbia, didn't show any benefit in people who got the procedure versus those who didn't in the placebo-controlled part of that trial. Yes.
So, I was on Lemtrada, and the reason I was put on that is because my Tecfidera wasn't doing much. And so the whole reason I went on it, as opposed to some of the other options, is because there was at least a hope that some of what I had lost would be returned, which did not happen for me, and now I'm in the middle of another relapse and went through another round of steroids and whatever, which, anyways, I'm still not in a good spot. So I was wondering, with the stem cells, is there evidence, like you say their goal is, for actual recovery of ability where it had been lost for some time?
So there's no proof yet. That's what this trial will hopefully, touch wood, hopefully show a signal in that regard. But we don't know yet, which is the reason for doing this large study across multiple countries, is to actually see if we have some suggestive data from small numbers of people with MS, especially looking at the recovery of vision. And we have a lot of data from animal models of MS. But like any other therapy for MS, we need to actually do the clinical trial to see if what we hope is the case really does turn out to be effective.
Thank you.
Yeah, so this trial was actually specifically designed to try and get at that with a lot of different ways of looking at ways of different outcomes to look at different ways of seeing if there was some evidence of recovery of function. Absolutely. Okay.
Hi, my name is Kim, and I'm the first Saskatchewan lady that had HSCT done in Mexico. And I feel absolutely fine. I had it done March of last year. I agree with you, it doesn't do anything for repairing stuff, but I didn't go there for that. I went there to have it halted, and it has.
Good.
If anyone has any questions for me, I can try and answer whatever you have, because I have been there and I have done it, and I'm one of 5 people in Saskatchewan that have had it done.
Good, okay. I'm glad you're doing well.
Hi, I just have a question. Are you just doing these studies or tests just on people with progressive only and not remittent?
No, you're reminding me of something I was going to say and forgot about, which always happens when I drone on too much with other things. So this trial was actually designed. The MESCAMS trial, the mesenchymal stem cell therapy trial, was actually designed to enroll people with relapsing MS, people with secondary progressive MS, and people with primary progressive MS. This is a very, very important point I should have highlighted, because the whole purpose of doing this trial was to see if this was something that showed benefit across a different spectrum.
Right.
Yeah.
Oh, okay, good. I was just wondering. And you're doing this study now?
It's ongoing now.
It's ongoing.
Yeah.
Okay.
Yeah.
And will you be doing any more, or that will be determined after you've completed this one?
So stay tuned. Hopefully there should be some answers from this study in, where are we now? In 2019.
Okay. Thank you.
So if one wanted to do that, where does everything take place? And is there any funding to get you to those? I'm assuming it's either in Winnipeg and Toronto?
Ottawa.
Ottawa.
Yeah.
Because if someone wanted to, do you have to provide your own flights and stuff like that? All of those kinds of things, and where would you stay?
So the Winnipeg site is now recruiting from people across Canada. And there are mechanisms to fund travel for people who are not locally in Winnipeg or Manitoba itself. Yeah. If they, of course, like with any clinical trial, even though this is a trial which is open to people with the different types of MS, you still need to meet specific criteria in terms of the characteristics of the person with MS, how their MS is doing to get into the trial. Well, the link is actually, I can give you the info afterwards if you want, but the information, the best way is actually through the MS Society portal, where it'll actually directly link you to the recruitment email.
That's a great question. I would also just add to, if you are interested in seeing what trials are accepting patients, I believe on the MS Society of Canada website under research, there is a place where patients can actually go and see. And I think that link maybe there as well too. So start there.
Yeah, because that will show not only this trial but all other trials across Canada which are actively recruiting for people with MS.
Oh, one more question. Oh, thanks, Rochelle.
Is there age criteria for participating in the research?
And with this particular trial, it's people between the ages of 18 and 50. So this is why? Yes, why? I know. There's even though this is a trial where we're trying to open it up to all different people with different types or variants of multiple sclerosis. With any clinical trial, you need to make sure that the people who you're enrolling in the trial are relatively the same in terms of their range of ages, gender, how their MS has affected them, all this type of stuff, because that's the only way that you can have balanced arms where you're randomizing people to get the treatment, not get the treatment. In this therapy, people who don't get the treatment in the second phase, but you still need to have some way of matching people who are relatively similar. And the age criteria, for what it was worth, was with the point had to be made somewhere, and 50 was what was used. Different trials are more restrictive. Different trials not so restrictive in terms of age, but it's very frustrating when they're concerned. There's a lot of people who I've wanted to enroll in this trial, who not just on age, but there's been something that's just been where they just don't meet the criteria. And this is the same for any clinical trial and any clinical investigator. And of course, the people trying to get into the trial, it's a source of enormous frustration. But there is the trade-off is that if the trial is done properly, we get an answer faster, one way or the other, which then opens it up to more people going forward. And in the same way that any other therapy, I mean, if I can't remember the exact numbers, but there were cutoffs in a lot of the other established therapies in terms of who would get or not get therapy. And then when the drug is on the market, we can be a lot more liberal in terms of that. Pediatric MS is the obvious example. I mean, I shouldn't say no, because now it's just one. Just recently was the first trial actually in kids with MS. But that isn't to say that kids with MS have not been treated, just been treated based on the adult trials. And the same thing would apply in any other group.
Okay, I think we have time for one more question.
I'm just wondering, I applied for all of in Alberta, Manitoba, Ontario, to get into all of these trials. And I was either too sick or not sick enough for them all. And that's why I chose to go elsewhere, because I was told stem cells were not going to come to Canada for probably another 7 years. And I was just wondering why they only take people that barely have anything wrong with them, as opposed to somebody that most of the people in this room have had MS for a number of years.
Mm-hmm. So it's, again, this just speaks to the fact that I think with any clinical trial, there's no way you can have the trial open to everybody who people want to get into the trial, people that we as investigators would love to have as many people as possible in the trial. But if the trial is going to be done properly, we have to make some concessions in terms of who is eligible for the trial so that we have a group of people who are similar in enough characteristics that we get the answer. The last thing we want to, the last, and if you think of sort of the bone marrow transplant trials, one of the problems is that so many different trials were just done at a single center. They all enrolled different types of people with MS, people with very aggressive MS, people who were not very aggressive but you thought might become more aggressive down the road, people of different ages, and they were all treated differently. And after all the hundreds of people treated worldwide with all these different methods, we don't have an answer as to who would be someone who definitely should be considered for a bone marrow transplant versus not. So the trade-off with a trial like MESCAMS, the mesenchymal stem cell trial, is that by having criteria where somebody who's had MS for 12 years is eligible to get into the trial, someone who has had MS for 13 years isn't. It's arbitrary, but you need to make those distinctions somewhere, because otherwise the data you get from the trial is not going to be helpful. And with clinical trials, the most important thing is that the people who actually are enrolled in the trial and are not only spending the time, the energy to come for the trial, but actually putting their own bodies forward for the trial, the last thing you want to do is have a trial that's going to be designed poorly and going to make all their effort meaningless. So this is the trade-off. But I totally understand you, because it's enormous frustration with anybody who wants to be in a clinical trial and can't get into one. It's enormous frustration.
Thank you so much, Dr. Marriott. I think just any closing comments from you?
Well, just to follow up on the fact that if you're interested, because the trial is open across Canada, by all means, the MS portal is the best way to reach the different investigators, and not only for this trial, but of course for other trials that are recruiting across Canada as well. So it's a very important resource. That's I think all I'd have to say about that. Okay, thank you.
Thank you. Thank you so much. Wow, this has been a really good day. How, just by a show of hands, how many people have learned at least one new thing today? How many people have made at least one new connection with a researcher, a peer, somebody they haven't seen for a while, or somebody they might connect with in the future? Awesome. And that's why we call it MS Connects, right? We always want to continue to at least provide opportunities to forge more connections. Before we wrap, just a couple of things. I'd like to encourage you to complete your evaluation form. Those are on the tables. I think there are pens on the tables as well. So please do take a moment to complete that, as again, it really does help staff and volunteers in planning for future events. And I believe, Lori, do we have a drop box at the check-in table where people can drop it, or we will also just check the tables before people leave as well too? But if you do think of it, please drop it in the box. We also recycle the name tags, so please take a moment to drop those off. Or if you're out and about shopping and you just want to be really friendly and introduce yourself to people, you can. I know I've certainly done that a few times. I do also want to ask, are you connected with us throughout the year? If you're not already following, if you're on Facebook and you're not following either MS Society of Canada or MS Society of Canada Saskatchewan Division, please take 2 minutes to click those like buttons. We put a ton of information out there. We do a lot of sharing of stories. We put out, when there's new things happening in the media, we put it out. That is your most probably timely and current source of information. We also do a monthly e-news that you would get if you have an active MS Society of Canada membership. If you need to check on the status of that, please have a chat with Stacy or Rochelle or Lori. We're happy to get you set up with that so you can receive that as well. So that's another great way to stay informed as well. Also, just a reminder, the Interactive Research Clinic is still open until 4 o'clock. There's no rush to leave. If you want to stay, visit, finish up your clinic experience, if you're interested in that, please do so. And I think we're going to have Dr. Levin come up right away here to make the fabulous draw. I think I get to be Vanna White.
Yep. Very good.
All right.
So thank you all for participating in research today. Again, the clinic is still open. If you'd like to finish up or even start from the beginning, there's no line, so it's a good time. But for those who've already participated, we're going to do the raffle for the swag. Here we go.
Yes, yeah, you can just leave them on the table.
Okay.
First one is. Oh, are there actually?
Right.
Yeah. It's a green ticket. Yeah.
Whoop, grab the mic there. So it's 5 zeros and then 5. 5 0 0 0 0 0 5. Ends in 5.
Oh, Maxine! There you go.
Great. 3 more. Congratulations. 5000, 4 zeros, 32. 32 at the end. 500032. 32 at the end. Okay. We'll hold on to that one for a second. Okay, this one ends in 3, so it's 5 zeros, and then 3. 5 0 0 0 0 0 3. Okay. And this one ends in 24, so it's 5 0 0 0 0 2 4. 24. Aaron, let me try the tickets. So wait, did I give out 4 of them? Yeah. Did I give out all 4? Yeah. Great. Okay, so Aaron, did you want to say a few last words? Again, thank you so much, everyone, for participating today and attending today.
Awesome. Thank you. Can we get another round of applause for Team Levin and Dr. Levin's team of many? We're so grateful that you and your team were here today, and I hope your team members found it beneficial. But
yeah, it was fantastic.
Obviously, our attendees, hopefully they had a great experience as well. Just a reminder of a couple of things we talked about. Make sure you follow us on Facebook, Instagram, Twitter, whatever your social media piece of choice is. Also the e-news. That's you can email us at info.sask@mssociety.ca. Just a reminder, if you are interested in doing some shopping with a real purchase, that the annual Lawson Heights Glitter shopping event is this Tuesday, November 20th. Tickets are $10, and all proceeds go to the charity that you purchased the tickets from. The MS Society is one of many charities that receives complimentary tickets from Lawson Heights Mall. So if you'd like to purchase tickets, just call or pop into the office on Monday or Tuesday. There is indeed so many exciting things happening right now, not the least of which is research in Saskatchewan, which we certainly heard about today. So I do hope that you are taking away with you some knowledge, some connections, but also an understanding of the great activity that is happening, and as such, maybe just a little more hopeful on what the future of MS care and research looks like in our province. I want to thank our programs and services staff again for coordinating this event, and certainly the collaboration from our Saskatchewan team with the researchers and clinicians. And many thanks to EMD Serono and Roche for making this event possible. Last but not least, I'd like to thank the Parktown staff on your behalf, both the AV and the hospitality staff, if we can get a round of applause, for making our day run smoothly. Thank you again. Thank you again for attending. Please stay, enjoy, visit, continue to make those connections, and have a wonderful rest of your day.